discussed. I'm going to discuss on a case of unilateral obstruction in a patient with advanced diabetic kidney disease. And this is a situation which we may encounter once in a while in our day-to-day practice. And this is important because, as you know, obstruction in a normal patient, the other kidney may be able to compensate, while in a patient with advanced diabetic kidney disease, the obstruction can result in sudden worsening of renal functions. And there are other challenges regarding whether to intervene or not in such a patient. And also, if there is a supraurinary tract infection, how to manage the UTA, what empirical antibiotics to choose. So through this case, we may be able to find an answer to these. And so this is a 76-year-old gentleman who was known to be diabetic for more than 25 years and hypertensive for more than 15 years. And around 8 years back, he was diagnosed to have kidney disease. And his baseline creatinine was 4 gram per deciliter 1 month back. At this time, he presented to the ER with complaints of right flank pain of 1 week duration associated with repeated bouts of vomiting. And his urine output was adequate. There was no history of any fever, chills, no history of dysuria or hematuria. There was no history of any breathlessness, pedal edema, no prior history of urinary tract infections, renal stones, or lower renal tract infections, and there was no history of NSAID intake. And on examination, the patient was conscious oriented with pulse rate of 78 per minute with a normal BP. Pallor was present, and there was bilateral pitting pedal edema. Systemic examination, again, the cardiovascular system revealed a murmur of aortic regurgitation. The respiratory system, there was normal vesical breath sound heard bilaterally. And per abdomen, the bladder was not palpable, but however, the left renal angle tenderness was present, and CNS was unremarkable. So we got a patient with a long-standing diabetes with hypertension with a prior history of CKD presenting to us with flank pain as well as vomiting with no history of fever with renal angle tenderness. So features which were pointing towards a urinary tract infection and possibly obstruction. So his labs showed an anemia, a mild anemia, and the creatine had slightly worsened to 7.5. Mild metabolic acidosis, as well as elevated C-reactive protein and features of CKD-MVD. So his urine revealed only 4 to 6 pus cells, and there are no other active sediments, and urine cultures were done, which was sterile, and blood cultures were sterile. So we have a patient who has urine culture was sterile, but however, he had elevated CRP with features of vomiting and flank pain in a diabetic patient. So the most probable clinical diagnosis was a urinary tract infection. So most often we find patients with multi-drug resistant organisms, but here the patient had a sterile urine. So can we have the poll 1?
Yeah, look, can we? Because one of the important things here is that what type of organism do we see? So how commonly do you see MDR? When you're talking about MDR, I'm talking about not about ESBLs, but about carbapenemase producing or XDR organisms. So that type of organisms, how commonly do you see in your practice? That's a question which I wanted to ask. Can you load the first poll? Host, can you load the first poll? The poll is not coming. Alok, are you there?
Yes, sir. I'm there, sir. I have already instructed.
Ah, yeah, here it comes. No, this is not the one.
Poll 4. Hello.
Yeah. Is it on its way or should be?
Give me a
I think, Jithin, you just continue the discussion. Once the poll launches, we can come back to that. Okay.
So you're talking about urinary infection. So most commonly it is in the multi-drug resistant organs, which we do encounter nowadays, and causing serious infections, and very difficult to treat also, especially in CKD patients. The antibiotic choice also is quite difficult in this situation. So
yeah, here it comes. Yeah. So the question is, how commonly do you see these carbapenems producing or XDR organisms in your practice? Do you see very rarely or occasionally, or it is not unusual or very common? So I think you can stop the poll and show the results. Yes, I think most people say occasionally or not unusual. So it's not very common and it's not very rare either. So that is unfortunate, because this is reality. What we're experiencing now is that we are going to see more and more organisms which are becoming more and more untreatable. So Jithin, continue with your presentation. We'll come back to this later. So your further clinical discussion.
sure.
Got stuck.
The slide. Yes. Just showing the epidemiology of UTI in a tertiary care hospital in West Bengal, where you can see the E. coli is the most common organism which is seen, and again closely followed by Klebsiella, Pseudomonas, Staph aureus infections. So again, multi-drug Klebsiella infection is on the rise and contributing to increased morbidity as well as mortality in our patients. So in the patient, we then proceeded with the ultrasonography. Here already come with an ultrasonography, which showed a right-sided hydroureter nephrosis,
பின்னாடி வாமா அப்புறம் அப்பா
grade 1 prostatomegaly, and there was no
mute yourself.
போய் பார்த்தா கண்ணு ஊ வந்துருமா கண்ணு
Rose, please mute the others. Continue. Jithin, you are muted now.
Can you hear me?
Yeah, now it's fine.
So the CTKB was done, which he had done from outside, and this showed a right perinephric fat stranding with moderate hydroureter nephrosis. This showed there is an evidence of obstruction, but however there was no calculi noted. So going on to the next poll.
This is one of the things we see quite commonly. It's this CT finding of renal fat stranding. Somebody else speaking? Is there a disturbance?
Sound is feeble.
Okay. Okay, now it's better?
Yes.
There's some... I don't know what's happening. Anyway, I think that's better.
Sir, someone has unmuted. That is the research.
Okay. Yeah, now, so this is the poll which I want, because a lot of signs on the CT, which are, so one, do you think that perirenal fat stranding is a strong sign of pyelonephritis? So only one of this is correct answer. Bladder wall thickening is a strong sign of cystitis. Hydroureter nephrosis is a strong sign of obstruction. And emphysematous PN is always associated with obstruction. So actually, many of these things are thought to be okay, but it's not always okay. So you can. So has everyone submitted the poll? Can show the results now. Yeah, I think everyone has got it right, because nobody believes that perirenal fat stranding is a strong sign of pyelonephritis, bladder wall thickening, and emphysematous TN. So just before we go ahead, I would just like to ask Srijit about this. Dr. Srijit, what do you think about perirenal fat stranding? How good a sign of pyelonephritis it is on CT? Because many times CT, they report perineal fat standing and say pyelonephritis in the same breath. Dr.
Uh,
Sridhar? Yeah.
Yeah, it is a common finding in conditions where there is renal inflammation, but I believe it is not specific for pyelonephritis as such. But it is a very, very common finding in
Yeah.
whenever there is some sort of renal inflammation. But it is not specific for pyelonephritis as such, unless there is a abscess or there is a collection. That's what I believe is the significance of perinephric fast standing.
Yeah, I think so. That I totally agree with you on that. Jithin, you can show us what other CT findings you find in urinary infections. Yeah.
So let us go into the CT findings of acute pyelonephritis. So most usually what you see is that's an enlargement of the kidney with the loss of CMD, as well as there may be wedge-shaped areas of hypo-enhancement. And perinephric fat standing may be relevant in a clinical context, especially if there are other features of infection, though it may be seen in other conditions also. And then you may have thickening of the Gerota's fascia and thickened and dilated pelvic calcareous system. So these are some of the findings which we see in acute pyelonephritis. So based on the findings of perinephric fat standing, elevated CRP in a patient with symptoms suggestive of UTI, we started empirical broad-spectrum antibiotics, which was he was started on meropenem, and he was put on cautious hydration, antispasmodics, alpha blockers, and our renal functions as well as her electrolytes were closely monitored, and CRP was also serially monitored. So going on to the next poll regarding the empirical antibiotic.
Can you load the poll, please? Poll number, next poll. I think one of the important things is what empirical antibiotic you're going to use for pyelonephritis. So one of the things are you going to use carbapenem if sepsis? Otherwise, use beta-lactamase inhibitor combination, or you're going to use only BLBLI even if there is sepsis, or you're going to use carbapenem for all even if no sepsis, or you would go for even higher things like ceftazidime, avibactam, or colistin as empirical therapy. So this is the point which we would like to make. So you can submit your answers. So there is some consensus on this, but of course, that doesn't mean everybody should follow that. Okay, can you show the poll results? Oh, carbapenem sepsis, I think everybody has gone for that. Actually, there is some evidence for this because there is a trial known as the Merino trial where they gave BLBLI plus or they gave meropenem for a patient sepsis, and all the organisms were sensitive to BLBLI. So that was the thing. And they found that if there is sepsis, carbapenems definitely are prevent more mortality than if you're using BLBLI. So even if it is that combination which is effective, if the patient is having feature of sepsis, you should start with the carbapenem. You can always de-escalate later once the patient improves. So, Dr. Sridhar, would you like to add anything to this? If you have.
Yeah. So my point is, they are absolutely right in that there is some evidence for basis for this practice. Most of people have opted for that, but to a great extent, I think this also will depend upon the context in which people are working. Because the spectrum, like in response to your first question, we see carbapenem resistance very frequently in our institution. So that I think it will depend upon the place as well as the, if you are working in a big hospital, tertiary care hospital, and all where antibiotic use is more, you are likely to have more. Spectrum is going to be different. And to great extent in our context, I think most of the hospitals will have their regular antibiograms shared by their microbiology department. They do that. I mean, for the last few years, the HICC is bringing out annually they will bring out antibiograms. So that is very, very useful. Many institutions do that. Our choice may depend upon the local antibiogram as well. That is the only, I think it is very useful to have that.
Absolutely. I think every hospital should, and every region should have their own antibiogram, and they should follow that. But I was rather surprised to hear that you're having a lot of carbapenem resistance. I thought that was restricted to
We are having.
private
So,
centers rather than a public hospital.
yeah, we are having a problem, serious problem of carbapenem resistance.
So you're talking about community-acquired infections, urinary tract infections, not hospital-acquired, or which one predominantly?
So this is basically mostly our own follow-up patients. It's not community acquired, not first time. First time people will not come to nephrology; they all go to medicine. So these are all our follow-up patients, transplant recipients, CKD people, no other CKD people on follow-up, dialysis patients. So I'm talking about that population, not the community acquired UTIs.
Okay. But even then, that is rather.
Yeah, we have a huge problem of we frequently use colistin, and our use of the ceftazidime avibactam has gone through the roof for the last couple of years. Not that we use it indiscriminately, but yeah, we use based on concern sensitivity. HICC, the Hospital Infection Control Committee, is involved in this. Yeah, so there is a problem.
So there is a monitoring system. So that is one of the other things which I would like to ask. So do you think there should be a monitoring system in every hospital for these antibiotics? That clinicians should not be allowed to use it indiscriminately because that creates problems.
That's question to me, Dr. Sadish.
Touchy subject.
That is to me.
It's a very touchy subject when you talk about it.
Yeah, no, is that a question to me you asked?
Yeah. So whether you should.
Absolutely. I think I totally feel that it should be there because there are a lot of aspects to the dosing and all, which with class clinicians we may not be aware. So our residents also will tell you HICC is actively involved. In fact, if we send a request for a blood culture, our residents are not allowed to draw samples now. The HICC people only will come and they have 24 hours cell. They only will collect the samples. So it's not that our residents cannot draw samples now. And they give advice they give a formal, every culture, there is a detailed report. And we can discuss with them also. So there are instances where we have used, for example, meropenem infusions for people who are resistant to meropenem also, but it works based on data. So I think they have a very important role to play. And of course, it cannot become a turf war. It can easily escalate into a turf war, but then that I think is a sign of, at least in our situation, it is not like that. It is a very nice, and I think we are benefiting significantly from inputs from the.
Yeah, muted.
Somebody else muted me. I don't know. I didn't do that. Yeah, but yeah. So there it is headed by a microbiology faculty. It's under the microbiology department. There is an HICC, and their inputs are. I find it very useful. I think it should be there.
Yeah, I think absolutely right. In our hospital also, there is a that monitoring of the use of carbapenems and other antibiotics which are above that, like ceftazidime, bactrim, colistin, etc. So immediately it is flagged in the system, and the ID consult will come and see and whether it is really indicated, and they will advise regarding de-escalation, etc. But I think that's a policy in place, which is very important. If everybody follows that, I think we will soon have a lesser amount of meropenem resistance and other carbapenem resistance which we are seeing. I think Jithin, continue.
Same thing. We also seeing more of this resistant bugs and use this ceftazidime avibactam also more often. And now we have got ID in place also, so they are frequently checking the dosing, which sometimes we tend to underdose also, especially with this colistin and polymyxin and all. So probably a proper dosing and scrutinizing will go a long way in optimal antibiotic management. So this patient, she had already received beta-lactam inhibitor from outside. So we had switched him over to meropenem when he came here. And subsequently a urology consultation was also taken in view of the obstructive findings which was shown on the CT. So they, as usual, came and advised for a immediate retrograde pyelogram with ADJ stenting. So the next question was to whether to go ahead with this the intervention or not. Here we have a patient who is having features of some features of you, but not very sick and not very septic, but his creatinine has gone up. So should we wait or should we go ahead with the procedure immediately? That was the next question in our mind. So going on to the poll 4.
Yeah, can you launch the poll 4? So it's a very simple question. So in a patient with mild hydronephrosis and pyelonephritis, would you advise DJ stenting in all cases? So that's a point of controversy in many places. So can you launch the poll? Yeah, here it is. I think we can end the poll and show the results. Yeah, most people say no. So I think Dr. Jithin will tell us what should be done.
So this is an area of controversy. Like many times, we'll be confused whether to go ahead with the intervention or not. So it all has to be individualized as depending on the patient to patient basis. So this patient he had features of urinary tract infection with obstruction, but he was not very septic or very sick. Many times we see that when the patient is started on empirical antibiotics, they do improve. And here the cause of obstruction was also not clear. Probably it was a papillary necrosis in the context of a diabetic kidney disease and features of UTI, which we assume that once we treat the infection adequately, it might resolve. So we went ahead with the conservative therapy.
Your slides are not moving. Stuck on poll 4.
Yes. So the big question. So the big question is whether to intervene or not. So to answer this, you have to think about two questions. One is whether the recovery of a meaningful recovery of kidney function can be obtained if the obstruction is relieved. And second is if this obstruction is this obstruction causing harm to the contralateral kidney or the systemic state of the patient. So these are the few indications of intervention. One, if the patient is having ongoing infection or sepsis, or if there's a progressive rise in creatinine or fall in urine output despite your conservative care, and pain that is not getting relieved with conservative care alone, and or if there's a bilateral obstruction or obstruction in a solitary functioning kidney, and if there is unilateral obstruction and you see there is a viability, which is assessed by the thickness of the cortex, which is if it is more than 1 centimeter, or a differential renal function, which you can assess with a diuretic renogram of more than 10 to 15%. So this is will see if there is a viable kidney which can be saved if you go for obstruction, if you relieve the obstruction. So then once you decide to intervene or not, based on these findings, the next question, how to intervene. So there are two options which may be putting in a DJ stent or percutaneous nephrostomy. So both have got its pros and cons, as well as clinical situations where they are more suitable. So for example, DJ stenting is best suitable for stable patient with a non-infected system, and especially when the obstruction in the lower urinary tract. And then a PCN is better suited if the patient is having sepsis, features of pyelonephrosis, or if the obstruction in the close to the upper tract, or if the stenting has failed. And this is digestion is obviously done by retrograde way, and PCN is antegrade percutaneous, and the sepsis risk is more with digesting, especially if the infected urine is present. And PCN, the infection risk is slightly lower. However, the failure rate is around 10 to 20% with the digestant. And many times, if digestant fails, you may have to go to percutaneous nephrostomy.
I think it's an important point. Which type of intervention we'll be doing? Dr. Sridhar, do you have any opinions on how you?
Yeah, so first thing, one point I believe is that if the diagnosis is an infected, obstructed system, that is a indication to intervene. I believe that it's possible that that kidney function may not improve. But even in that case, I think if my diagnosis, okay, how do you make that diagnosis is a little not very explicit, but then if the diagnosis is an infected and obstructed system, I would generally ask somebody to either the interventional radiology or the urology to intervene. That is my first point. Second thing, and I think there is some data also showing that if it is an infected, obstructed system, early intervention improves outcomes. Okay, so and what to do? Mostly people, I think, will end up doing digest stenting. Is what in our system usually what happens. Only if the stenting is technically difficult or it doesn't work, then our urology people opt for PCN. So generally, that is what this is not dictated by us, unfortunately. This is usually decided by the urologist. Okay, we can talk to them, but then this is not that intervention decision is usually not entirely in our hands. But generally, what happens is if intervention is required first, urology people will try to stent the patient, and if it doesn't work, then they go for PCN.
Yeah, I think that is correct. And for PCN, we need to have a properly dilated system. If it's a mildly dilated, then that may be a problem. But if it's well dilated, should not be a problem for interventional radiologists. I think in your system, are the IR people doing it or the urologists are doing it, PCN?
No, it is mostly the IR was not there till a couple of years back. So only last 2 years they are there, but mostly it is done by the urologist.
Okay. So I think that is actually an important point. Would anyone else like to comment on this, on about PCN and using? I noticed Martin, you're there. Martin, you want to make any comments?
Sir, thank you. Sir, I have a institutional bias because I work in a urology center where we have 7 urologists, 7 urologists. So we very frequently get such cases referred from outside and all. But a big problem that we face because we cater mainly the lower strata patients socioeconomically, many of them may not be willing because of the financial issues. So in such cases, what we have seen is we continue treatment with IV antibiotics and we closely monitor the patient, the tachycardia, the sepsis part, the counts, how they are rising and all, how the urine output is there, how is the creatinine trend moving. And many a times we have gotten away without stenting. So every time papillary necrosis, which is causing the obstruction, needn't be stented, but that patient should be closely monitored. And PCN, I am not a big fan because every time a PCN is put, you lose a lot of nephrons. And most of the PCNs usually are followed by some hematoma, renal hematoma, all these things, even when you get a well-dilated system. Whenever possible, we always try to do a DJ stenting. And if that fails miserably and there is no other way other than to relieve the obstructed system, then only we go for PCN.
Okay. In general, regarding relief of obstruction, Jacob sir is also here. Jacob sir, can you about this point about hydronephrosis and whether you would release it or not? Dr. Jacob?
Thank you. I also agree that if it's an infected and obstructed system, definitely go for relief.
But that's a point. How will you determine whether it's infected?
If it's not responding to the if it's not responding to the antibiotic, creatinine is going up, ultrasound is showing still persistent hydronephrosis, then I would think definitely you should be relieved. Again, I just had a small controversy about the choice of antibiotic because everybody was talking about carbapenems and all that. See, my impression is that somehow aminoglycosides is less favored by the infectious disease consultant. They are all more for carbapenems and ceftazine avibactam. But I have personally found that somehow microorganisms somehow do not develop resistance to aminoglycosides as commonly to the other drugs. So I often combine, the advantage of giving aminoglycosides in renal failures, you can give it a very low dose. So 500 mg of amikacin, you can give probably once in 24 or 42 hours, then I think that's quite effective. And I generally combine this with cephalosporin sulfate. Somehow, surprisingly, even though the hospital where Satish works is only a few kilometers away from medical college where I used to work. So surprisingly, the antibiotic pattern we found in medical college was most of the microorganisms were sensitive to cephalosporin sulfate and amikacin. So it was a favorite combination. And I very rarely have found the patients not responding. In which case, then I would go for a carbapenem. That's a very small percentage. Somehow, I feel that amikacin is somehow not utilized properly. It's a good drug.
Yes, I agree, but I don't know whether we can. One of the problems is that in a very sick septic patient, hypotension on inotropes, probably it will be better to go for a carbapenem or something like that. But somebody who is much more stable, like you said, you can give amikacin. One of the advantages, you can send them home on once in 2 days therapy or
Your
something.
dose, I mean, a reduced dose, and it's a quite cheap drug. But
Yeah.
surprisingly, I have also noticed that all the infectious disease consultants are somehow not very happy to give amikacin.
I think Cipla also will be happy to hear that because they have the plasmomycin new aminoglobulin.
But even amikacin is good enough. Cheap
Yeah.
drug, and effective.
Dr. Beena, you're also there, no? Beena.
Yes, I have a department. The urology is very much, we have close interaction. I find that in severe sepsis, even some complicated patients, urologist does support with the help of the anesthetist. We do get away with patients who have come very sick. And I find that the ICU management is much easier. And the resistance to antibiotics is also less because of that. And I am also a great friend of aminoglycosides. I do use it, and I do give it in stable without any thrombocytopenia or coagulation abnormality. I do give it IM. So it is supposed to remain more in the system when you give it IM than IV, and I feel. And it's been very helpful medication. When you find the counts are going up, and this really has helped me out, aminoglycoside. And yes, the DJ stenting has helped me out in many conditions. I never had to go for PCN. PCN only when there is some other like malignancy or some other complications. And papillary necrosis, actually, about 15 years back in Cosmo, there was a patient who had come for actually ureteric calculi, and he was, it was DJ stenting was done. He had gone home and came back with infection. And because of that, he was admitted in nephrology. And I found that he was, and I sent this for tissue diagnosis. And out of the blue, the pathologist comes up with Aspergillus niger. So I could treat the patient with the biopsy report. I could treat the patient for, in those days, finding a fungal infection and all was not very easy. So treatment with amphotericin, and the patient who had severe renal failure, the creatinine which had gone up to 8 without dialysis, he came out with a stable creatinine of 2. And so a very good relationship with the urologist is very important in these cases, because diabetes is so common, and urinary infection invariably they develop. So that's
Absolutely,
been my
yeah.
experience.
I agree. I think all words of wisdom from everyone.
Even gentamicin is okay, sir. Gentamicin, because my patients are very poor. I do get away with gentamicin. If not, I mean, depending on the grade, amikacin or gentamicin. I've not gone further than that. Thank you.
Okay. Jithin, continue.
Like everybody said, so if it is an infected urinary system with obstruction, so usually most of us agree with going for a relief of obstruction. But in this case, the patient had presumably infected system, but he was not very sick, and we thought that we will give a trial of antibiotics to see how he's responding. So with the empirical antibiotic therapy, in a couple of days, he became symptomatically better. His hydration was closely monitored, as well as his creatine values also was slightly coming down. And but however, on the background of the obstruction, we wanted to know whether it was significant or not, and before proceeding with the intervention. So we went ahead with the diuretic renogram, and this was reported to have bilateral unobstructed flow. Slow continuous drainage was noted, and repeat ultrasonography was also done, which showed no evidence of obstruction. And thereafter, he was continued on the antibiotics and with proper hydration, close monitoring of his renal functions. So this diuretic renogram was done with IV bolus of DTPA, and furosemide was given IV at the start of study and 2 hours later. And static pre-void and post-void as well delayed imagings were obtained. And this you can see the two curves. Both the kidneys. There is slow but continuous drainage in both the kidneys. Though the split function was also assessed, which showed a GFR of 9 in the left kidney and 11 in the right kidney. So both of them were almost equally affected, and severe parenchymal dysfunction was noted, but there was no obvious obstruction. So, so in the absence of obstruction, we continued with the antibiotic therapy and decided against intervention. And in the coming days, there was stable, steady but slow improvement in his renal functions, and his urine output was adequate. So renal functions started improving gradually. So this patient could be managed with IV antibiotics and other supportive therapy alone, and intervention could be averted in this patient. And here, the final diagnosis was an acute on chronic kidney disease, and the acute part was improving, probably related to the obstruction as well as the infection. And the acute pyelonephritis, doubtful, as the cultures were negative, but however, the other features of infection like pain and this elevated CRP as well as perinephric fat standing on the imaging, and obstructive uropathy with moderate hydronephrosis, probably renal papillary necrosis, because subsequent imaging of that renogram showed relief of obstruction. So this is our patient. This is a clinical situation which I wanted to share with all of you. So we could manage. So what the key takeaway is, not all of these obstructions need to be intervened, and there are careful subset of patients who you can manage with IV antibiotic therapy, and on a case-by-case basis, you might have to start appropriate antibiotics and do imaging to decide on further